2, 1. Please start, ma'am. We are live.
Sure. Namaskar and good evening, everyone. I welcome you all for today's exciting webinar on lung cancer update, new development and best practices. For this, I would like to invite Dr. Praveen Jain, who is Senior Consultant and HOD Medical Oncology, Akash Healthcare Delhi, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
So 1 second, please. So, hi, good evening all. So, I welcome you all for this academic fees. So today we will be discussing about the lung cancer updates, and there will be 5 talks by the eminent speakers. And without wasting any further time, so I'll invite the first speaker, Dr. Pratik Chandrani, who will be speaking on choosing essential biomarker or NGS in early and late stage non-small cell lung cancer. So Dr. Pratik, are you here?
Yes, hello.
Hi, Dr. Pratik.
Hello. Hi. Shall I start my screen sharing?
Yeah, I think we are good to go.
Okay. Okay. So, good evening, everyone. I'll be presenting today on molecular biomarkers for lung cancer. And let me first set up my screen share. Is my screen visible?
Yes, your screen is visible and you're audible, Dr. Pratik.
Okay.
So, but your voice is very less. So the
is it better now?
No, it's still very low.
Let me change my microphone.
I think is audible enough.
Okay, is it audible enough? Is it better now?
Yeah, carry on.
Okay, thank you. So, so today's presentation is developed by AstraZeneca. Let me first clarify is this molecular biomarker testing in lung cancer we are going to discuss today. So in today's presentation, we'll be talking about lung cancer in India, biomarker testing as a standard of care and test as of now in Indian settings, and evolution of biomarkers, and what is the future that we are looking forward to, and key takeaways from the whole presentation. So to begin with, as per the Globocan data, lung cancer is one of the most predominant cancer type in India, and particularly when we talk about male and female, we see lung cancer cases rising in male, but in female also it is among the top 5, and combined together they fall at third rank overall. So lung cancer is a major burden in India, as what we have also seen in other part of the world. And to provide good care for this lung cancer is still a daunting task. I'm saying still because many of the molecular biomarkers are improved lung cancer patient survival in past few years, but still we haven't been able to cover the 100% spectrum of lung cancer patients under the umbrella of targeted therapy and molecular therapy. So there is still a lot of room to improve further. So to take both of these learning, let us dive into this, this detailed and a bit complex slide which has evolved over the years, and it has shown us that how molecular spectrum of lung cancer has gone from 0 to almost 0 as of now. So we know KRAS is most predominant cancer type in most prominent oncogene in lung cancer, followed by EGFR, ALK, which are already standard of care, and then MET, HER2, ROS, BRAF, RET, NTRK, PIK3C, and MEK. These are the relatively new biomarkers, which are in lower frequencies, but slowly they have gained standard of care practice in lung cancer. BRAF and NTRK are also showing good clinical results in the settings of pan-cancer therapeutics, which is also a very good sign. This has left us with 31% of the lung cancer tumors for which still we don't know a therapeutic target as of yet. And still there is a lot of room to work towards identification of novel therapeutics. Now here, these new therapies which have particularly highlighted unique cases in lung cancer is for EGFR rare mutations, uncommon mutations, for which advanced therapies like mobocertinib or other therapies like even osimertinib has also shown good response in certain rare EGFR mutations. And HER2 directed therapies have also found its way in lung cancer, where HER2 amplified and HER2 mutated lung cancer cases are now being detected with the help of comprehensive genomic test. And one should pay attention to it. Earlier, they were not a part of a typical lung cancer panel. Moving on, this lung cancer biomarker targeted therapy has also shown good clinical benefits overall. So in this particular study, what we are seeing is overall grouping of all the biomarker targeted therapies as opposed to all other lung cancers which are not receiving targeted therapy, but they are receiving any other standard line of therapy. And the survival gain we get to see on an average is 7 to 8 months between these two groups, which is surprisingly good. But in my personal opinion, this can even go beyond if you further do stratification. There are certain targeted therapies which are performing very well, and they are surviving. Those patients are surviving beyond 24 and 36 months, and certain targeted therapies are there which are not yet doing so well because maybe the drug efficiency needs to be improved, or there needs to be some other complicated considerations while taking the therapy decision making. But overall, this data is clearly showing how well targeted therapy is working as opposed to non-targeted therapy. Moving on, the international guideline that we see as of now all across the world for lung cancer targeted diagnostic and therapy decision making, we see more and more markers are getting their place in this chart. As we can see, ASCO and NCCN mostly support all of the biomarkers for the testing as compared to AMP and other guidelines which are relatively less frequently updated. But I'm sure in the next iteration of this guideline, all of these biomarkers will be also covered in that. Overall, the take-home message that we need to take as of now is biomarker testing and their targeted therapy is already a standard of care. And given that there are many handful biomarkers, it is becoming imperative that we start considering NGS as a very serious diagnostic test, and we start using NGS as much as possible. And there are certain post-related concerns still involved with NGS test, but the more we push, the more market placing will be improved, and the more patients will be able to take benefit from multi-gene comprehensive NGS test as per recommendation of NCCN, most recent updated, as well as ESMO, ASCO, and AMP, and so on. Now, what kind of panels we use? That also is a separate question. In NGS, we have multiple choice. One is a DNA-based test. Second is DNA and RNA both integrated together in a single test. Another type of choice we get is a small panel, say 4 gene or 5 gene panel, as opposed to a comprehensive panel having say 200, 250 genes or 500 genes, and so and so. Even now, Indian specific panel is developed by Forbes Care, includes 1,000 cancer target genes, and all of them can give you a very comprehensive options for the patient, which can go beyond the standard line of care. One can also consider the ongoing clinical trials and advanced drugs which are not yet available in the market under obviously the approved trial settings. So those kind of options are available. Our recommendation would be to go for the minimum comprehensive panel somewhere in the range of 40-50 genes, which should be able to detect insertion, point mutation, deletion, DNA based, and it should be able to detect fusion genes based on RNA. Some of the techniques are also available where fusion genes are detected from DNA as well, but those are not yet mature enough and they are not sensitive enough. So our recommendation is to go for this integrated test where DNA, RNA both are considered, and the panel size should be at least in the range of 40-50 to be the minimum comprehensive panel. And if preferable, if cost and budget is allowing, then one should go for larger panels as much as possible. Now, during this regular testing, we also run into several challenges where certain type of alteration detected by NGS are ambiguous and in more conventional terminology, you can say they are equivocal type of signal as people are familiar with IHC and FISH frequent running. So, for example, Al-Cross fusion or, for example, NTRK fusion, the non-standard fusion partner, can be, not confidently detected sometimes. Sometimes it may happen that you have a clear signal of gene fusion, but the overall coverage of the sequencing is very low, and hence the final conclusion is not reliable. In such cases, having complementary IHC and FISH can be really helpful. And many of the times at Tata Memorial Center, we recommend NGS service provider to go for independent validation of gene fusion right away, even without waiting for our intimation. If coverage is low, if there is any technical issue, if there is anything to keep a doubt onto it, then we recommend them to straight away go for independent test and then submit us data altogether. So that saves a lot of time in critical decision making. So along with this NGS based panel, IHC and FISH continues to serve as a good comprehensive solution for lung cancer, and that is true for Indian setting as well. Now, how these biomarkers have evolved over the time, and where do we stand today? So let's look into a bit of the history, and in this history, first we'll go to more classical, points where once upon a time it was a big debate what kind of tissue to use, and the tissue was supposed to be a very big issue. But with the help of technology, now we are very much better placed. But still, it is still a concern, and it is still a factor to be considered. So here I am summarizing it in these three different ways. At present, we either use tissue and tissue-derived FFP block as a primary source of material for the test. In some of the settings, we use cytological samples and the cytological sample derived block as a secondary material, particularly in the patients having a lot of fluid tissue available, or brain metastasis and so and so. And in the third setting, we use liquid biopsy, true sense of liquid biopsy, where we simply use blood and blood extracted plasma for cell-free DNA test. Among these three, the best performing is primary tissue even as of today. Along with that, cytological sample also performs quite well. Liquid biopsy is still a bit of a challenge as of today, particularly when it is not being used through thoroughly tested and highly sensitive platforms. So there are several different service providers which are not thoroughly ensuring all the controls while performing liquid biopsy based test. So false negative becomes still a big of a problem in there. But relatively, liquid biopsy technologies have also matured enough and it is ready to be used in the day-to-day practice. On the other side, we need to figure out DNA, RNA, and protein-based tests, and those three are also standard of care. DNA-based NGS test for targeted sequencing, which also incorporates transcriptome-based, RNA-based fusion, is a standard of care as of now. Protein-based test is not so much into standard of care except for IHC and the classical techniques. Proteomics and other techniques are still immature to using day-to-day practice. But I would still recommend that in challenging cases you can definitely tie up with a basic research laboratory, as what my laboratory at Tata Memorial is focused into, and there are several other laboratories out there who can help you, particularly take a particular patient case and give you more insight when other options are failing. So that's the regular thing we do here at Tata Memorial, and we often come across cases where this kind of ad hoc test really becomes helpful for additional learning, and that gives some more options to the patient. So that's about the overall landscape of tissue type and biomaterial type that we use in the testing, and that everyone should be aware of. So gold standard is use the FFP block, preferably from the tissue, or if not possible, then from cytological FFP block, and increase the use of liquid biopsy in the subsequent line treatment. Mostly in second and third line, liquid biopsy is very difficult for lung cancer patients, and that's where liquid biopsy based test can be really, really helpful. And the cost of liquid biopsy test has also gone down in the last couple of years, so it is becoming more and more affordable. Integrated DNA RNA test for NGS based platform is a gold standard, and one should insist on those kind of solutions rather than using any one of them at a time. Protein based test, IHC, is a gold standard. Other techniques can be used with the help of technical experts and research laboratory, keeping them on board. Moving on, we have also seen how test has evolved in the terms of expansion of the kit. Initially, I remember 5-6 years ago, the lung cancer panels were always used to be, 4-5 gene panels, and those were the most cost-effective solutions. Then people started using 52 gene panels, which were commercially available, and because they were produced at the commercial scale for the general market, the relative cost of 52 gene panel was as much as we used to do in-house 4 or 5 gene panel. So we switched it to 52 gene panel, but out of those 52 genes, we used to only focus on 4 or 5 genes at a time. Now we are into the era where, yes. Okay, so now we are into the era where the lung cancer panel has expanded beyond those classical 4-5 genes, and it includes BRAF, LTRK, RATE, MET exon 14 skipping, and several different variants, NTRK 1, 2, 3. Those all are, even though detected at lower frequency, but they are regularly detected, and those patients should definitely get first option of targeted therapy whenever they are found. Moreover, PD-L1, which we used to always test by IHC, now can also be tested by NGS. So NGS is now turning into a one short solution which can allow you to detect all of these. Beyond this, now tumor microbiome, tumor mutation burden is coming up as a novel biomarker, and tumor microbiome, our own work is going to be out soon. So those kind of things can also be integrated with NGS. So over the time, I believe this list will keep expanding beyond the list that we use today. And the more comprehensive panel one is able to use, the more comprehensive NGS, more comprehensive next generation therapies one can offer to the patient. Now, in this, there are multiple ways these therapies are adopted over the course of period of the patient. So one is at the diagnostic stage, where we want to make initial decision making which therapy to use for the curative intent. There, most of the tissue-based comprehensive and CS panel is recommended, and the ctDNA can have its own utility if in case the tissue is not sufficient for NGS analysis. Then at Tata Memorial also we recommend to go for liquid biopsy and immediately do a comprehensive NGS test. But in most of the cases, tissue-based testing is recommended. During the monitoring period, when we have started the therapy, say for example, patient who is initially positive for EGFR, and we have initiated various EGFR therapies. So first we start with say gepitinib and show. Then every few months we go for liquid biopsy test to monitor it. It's not being followed for all of the patients, but whenever we see enough clinical evidence, we immediately go for ctDNA biopsy. Even if the tissue biopsy is not possible, then ctDNA biopsy is allowing us to get valuable insight. And in several of the cases, we have identified other bypass mechanisms activated, along with the EGFR still being present. And then patient was immediately switched to a combinatorial therapy in which gepitinib plus chemotherapy was given. And our data has shown that this works very well. This is able to cope up with several different resistance mechanisms which are not the conventional resistance mechanisms. So that's something that can be really helpful at this stage. And second is to use ctDNA based test when tissue is limiting. As I said, sometimes at the baseline itself, after doing the initial biopsy, if tissue is not adequate or if there is no sufficient DNA extracted and if NGS is not possible, we recommend to go for ctDNA. Or even at the time of resistance development, if repeat biopsy is not feasible, we confidently recommend ctDNA, and we are generally getting very good results in that. Now, in this setting, this one last point that we need to understand is that complementarity work. So initially, you may go with tissue biopsy, and initially you may get one landscape which shows maybe 4 or 5 different locations. Now, 6 months down the line, when you do ctDNA based test, only one of that biomarker is present, and others are not present. So that doesn't mean that there is something wrong with the ctDNA test. As I said, false negative is still a problem in ctDNA, but a ctDNA based observation becomes quite complementary to the primary tissue based profile. And one classical example, as I showed here earlier, when we switched to gepitinib plus chemotherapy. Another such example we have observed in practice is patient is positive for EGFR mutation in the initial stage. We give the EGFR TKI, and then after a few months, patient start showing symptoms of progressive disease, and then we go for a repeat biopsy, and we are not able to. Then we go for ctDNA based test, and we detect MET exon 14. We don't detect EGFR, but still we know that ctDNA has tendency to show negative results. So we continue combination of EGFR TKI with MET inhibitor, and then down the line when another biopsy was done, again EGFR was detected. So there was a durable response, there was a good response to this combination, and in that way, what I'm trying to say here is that ctDNA can act as a complementary test in several different challenging cases as per the need. Further moving on, we all know TRACERx study. It is one of the landmark achievement in the field of lung cancer, and TRACERx study has again shown the relevance of liquid biopsy, where 93% of the patients with the disease recurrence were MRD positive, and 90% of the patients without recurrence were MRD negative. So sensitivity and specificity both were very well established as a part of this study. Now, MRD is a very well established problem in leukemia and all, but in lung cancer now we are learning that the same concept and same technological investment can be really helpful. So that's something that even we haven't implemented in practice at the large scale, but with the help of this data, we should use these ctDNA based tests as much as possible. Now, there are certain advantages and disadvantages obviously associated with it. We all know about majority of these points. I will not go into very fine detail of it, but let us quickly go through it. So sample acquisition in the case of tissue is a bit of a problem, which is much more easier for liquid biopsy. Repeat sampling is definitely almost impossible for lung cancer tissue. We cannot ask for tissue biopsy every month, but we can keep collecting ctDNA every week or as closely as possible in the timeline. The biological correlation of histology and cellular phenotype and adjacent tumor, normal tissue contamination and so and so are a bit of a problem for tissue biopsy, which is not there in liquid biopsy. It is representative of the whole of the tumor type, whatever is present over there. Sensitivity of the assay required for the tissue biopsy is a good advantage, as it can work with much less sensitive technique with much higher reliability. But in the case of liquid biopsy, we need to have the highly sensitive NGS techniques in place, which is a bit of a big problem for liquid biopsy. So this is where the roles are reversed. There, tissue biopsy is
Sir,
much better option with respect to liquid biopsy.
Dr.
Yes,
Prateek, I request you
yes.
to conclude your talk in next 2 minutes. Thank you.
Okay, sure, okay. And then analytical standardization is again linked to sensitivity of the assay because it demands much more sensitive technique. A lot more standardization is required, and because of that reason, a bit of less clinical evidence is there. But as I said, as TRACERx study has shown, and as some of the case reports that we have learned through, the clinical utility is very high, and with the help of more technological advancement, we'll be able to validate and show that. So this kind of test will allow us to go through various changes of biomarkers over the course of therapy and consider them for various targeted therapy options or combine targeted therapy with classical therapy options or switch from targeted therapy to classical therapy as soon as possible when we detect progression to targeted therapy. And that's where these additional techniques can further be helpful. Now, NGS post, we all know, as a single gene-based test will be much more cost-effective, but NGS is a little bit costly in a single gene-based test. But when we are talking about multiple gene-based test, this role is reversed, and NGS is much more cost-effective, and turnaround time is also much shorter as opposed to single gene-based 5-10 gene testing. Furthermore, the type of alteration that one is able to detect using NGS is also much more as opposed to single gene based test or classical test where IHC and microarray based techniques are being used. Most of these biomarkers which are commonly usable for lung cancer, they all are detected at variable frequency and they all have multiple different type of alteration. Those all are covered through NGS panel, but some of them are only covered through other classical techniques like PCR, IHC, PEACE, and so on. So that's why nowadays NGS is highly recommended. And with the cutting edge competition in the market, NGS cost has drastically come down, and the more we use it, the more it will come down. So that's the thing that we need to always keep in the mind. Furthermore, for EGFR mutation testing, people have shown various challenges, and in there I will, because of time constraint, I will quickly go to the point which is of most critical. Even in surgically resectable samples, EGFR testing is recommended, and people have shown that EGFR mutation positive patients get much more benefit from TKI, either in as a curative intent or in adjuvant setting, and that is something that one should pay attention to. Furthermore, in EGFR, people have figured out several low frequency uncommon mutations which have a different sensitivity to various different TKI, and the more work, more data has been generated in last 1 to 2 years, and now we know which type of alterations are showing sensitivity to which kind of TKI, and one of such is EGFR exon 20 insertion, which can be detected by NGS very well, but it is mostly missing from the PCR. And these all patients are also responding very well to third generation and other advanced line of TKI, so that one should pay attention to. On the other hand,
Sir, please conclude.
Yes, so ALK is another established biomarker, and we all know PEACE and IHC are gold standard, but now NGS is also equally reproducible for ALK. It is equally reproducible for ROS, and it is equally reproducible for BRAF mutations, which are observed at about 0.5% frequency, and MET exon 14 skipping is the highlight. This is very highly sensitively detected from NGS, but not by classical technique. So one should use RNA-based NGS test for very high confidence MET exon 14 skipping, but even DNA-based tests are also performing good. So the take-home message is that NGS is a gold standard, and switch to NGS if you haven't yet. Furthermore, these all rare alterations of biomarkers are all covered in comprehensive NGS panel. So go to NGS as much as possible. So that is covering the entire landscape of biomarkers, and their current therapies is available through a single test of NGS. And then PDL1 is again now doable through NGS. And I'll skip through this data, but many of the people have already presented this, so I'm sure most of the audience are little bit aware of it. My personal recommendation is ask for PDL1 in your NGS test. It will give you an early glance of PDL1, and if it is positive, immediately follow up with the IHC and do the confirmatory test if you require. If not, in my opinion, NGS test is good enough. So the conclusion is biomarker testing is a gold standard. A multiplex test covering at least 15 different biomarkers is already a standard in the field as of now. And adequate tumor content, at least 10%, is really good enough as per the today's technology. And within 1 to 2 weeks, you can expect the result, roughly about 10 working days. And this high throughput test will give you one-shot solution for everything, including precision medicine, which includes targeted therapy, molecular targeted therapy, as well as personalized immunotherapy. So my high recommendation to use NGS for your day-to-day testing and make it more affordable for all the patients. Thank you, everyone. That
Thank you.
basically concludes.
Thank you, Dr. Pratik, for the very elaborative lecture. So I don't think so. In the interest of time, we will have to move to the next lecture. If there are any questions, I think uh, you can put it in the chat box, and we can take it up at a
Sure.
later time.
Sure.
So I'll invite the next speaker, my dear friend. So Dr. Pankaj, who will be speaking on Rucaparib or PARP inhibitors changing treatment landscape in the maintenance therapy of ovarian cancer and beyond. So Dr. Pankaj.
Well, thank you, Dr. Praveen, for giving me this opportunity to talk on this platform. And I want to share my screen. Yeah, I think now. Just yeah, hope my screen is visible.
Yes, sir.
Yeah. So the topic would be the PARP inhibitors, how they have changed the treatment landscape in ovarian cancer and beyond. So this was an unmet need to improve the outcome and survival in the patients of CA ovary. Since we know in advanced stage, the outcome is not so good. Overall survival in Indian patients in stage 3 is 28 months and stage 4 is around 12 months. And
Dr. Pankaj Goyal, you are not audible.
Pankaj sir, not audible, sir.
So can someone call Pankaj?
Yes, sir, I am calling.
Am I audible now?
Yes,
Now
sir.
you are audible.
Okay, I'll share the screen again. Can anyone share the slides? There is some error from my side.
Okay, sir, we are sharing by us.
Just a minute. I think it's active now. Wait.
Okay, sir.
Yeah. Am I audible now? And is it visible?
Yes, sir.
Yeah. So I'll start from where I left. So in the patients, so if we see the investigation assess PFS, the outcome was very much similar as the olaparib, as we had seen in the Solo 11 trial, in which at 1.5 years, more than 60% did not had progression, and so we can say that this was doing equally good as the olaparib. So choice of therapy, if we talk about rucaparib, basically these are the patients who are HRD positive. They can be HRD, the BRCA wild type or BRCA mutated type, and we see that the PFS as compared to 14.7 months was not reached in the drug active drug arm, and in HRD in the patient who are BRCA wild type HRD positive, again we see that 2 to 3 months difference was there in the PFS. Olaparib, they had taken all these patients and they had seen that the OS was around more than 56 months. And olaparib plus bevacizumab, we had seen in the Paula trial and niraparib in the Prima 3 trial. And bevacizumab PFS includes treatment maintenance therapy. And as we have seen in bevacizumab maintenance arm also, one of the trial 0 to 1 to 4. So there's a query whether we can limit BEV in treatment and whether we can still go ahead with the single PARP inhibitor and it can do that better as compared to the bevacizumab maintenance, or we have to go for a double agent therapy. So then we had MITRE 25, which was a phase 1 study of rucaparib in combination with BEV, and maximum tolerated of rucaparib was 500 mg twice daily when given with bevacizumab. And randomized phase 2 portion of MITRE 25 with further investigate rucaparib maintenance treatment with or without bevacizumab in patients with newly diagnosed stage 3 or 4 ovarian cancer who respond to carbo and pecli. So this was a rucaparib dose intensity, and more than 70% continue to have the maximum dosage that are more than 80% of the patients received more than 500 mg BD dosage for 12 months. So for these are the first line maintenance options. If we are having a new patient who has done good on the first line therapy, then if patient is BRCA mutant, add a PARP preferably. And if it is the BRCA wild type of mutant, if it is the HRD positive, we should add PARP. And if patient is HRD negative, then we have the option of continuing with bevacizumab, if the bevacizumab has been used in the primary therapy. And if the patient was on bevacizumab based therapy and patient turns out to be BRCA mutant HRD positive, then on the bevacizumab itself, we can add a second drug, that is bevacizumab, as maintenance. So 50% of high-grade serous ovarian carcinoma have alteration in homologous recombination repair, and this is being used to have more efficacy with the maintenance therapies. And this is the breakdown of HR positive versus HR deficient CA ovarian cancer. And we can see that more than 50% of the patients can derive benefit out of this. And maybe platinum sensitivity is a better marker for the response with PARP inhibitors, as we have seen. At the most of the patients who are HRD positive, they are sensitive to platinum sensitivity. So it can be an indirect marker that these patients will derive benefit with PARP inhibitors. And if, however, the patients are HR deficient and they have this resistant PARP platinum resistant, then they might not derive that much of benefit. So platinum sensitivity is considered as substitute for HRD. Due to this fact, many trials now consider platinum sensitivity as one of the criteria rather than the just seeing the HR deficient or proficiency. So it should be kept in mind that platinum sensitivity may also result from defective nucleotide excision repair, which might not have been tested in various trials. So rucaparib FDA approves regardless of BRCA status in platinum sensitive as standard of care. Ariel 3 was a trial in the rucaparib maintenance in platinum sensitive recurrent ovarian cancers, and they had taken the patients who had received two or more than two lines of chemotherapy and randomized them to rucaparib versus placebo. And this was the investigator assessed PFS in the BRCA mutant HRD positive and intent to treat population. In all of these, we see that these two curves are wide apart, hazard ratio being 0.23, 0.32, and 0.36 respectively, and PFS basically doubled in all of these. So that is why this is being recommended, irrespective of BRCA positive or negative. If patient is HRD and or BRCA mutant, then patient is a candidate. And similar results we had seen in the BICR SS progression-free survival. So this is the progression-free survival in the intent to treat population. We see that rucaparib demonstrated PFS of more than 1 year as maintenance therapy, and 65% reduction in the risk of disease progression, and 24 months PFS in 40% with rucaparib versus 9% in placebo. So rucaparib is the only PARP inhibitor to demonstrate PFS of more than a year as a maintenance therapy, regardless of BRCA status. And this was the PFS. We see that in most of these subset analysis, we see that the patient derive benefit from the PARP inhibitor, whether they are platinum sensitive or platinum resistant, and irrespective of their response to the platinum-based therapy. So LOH high or low, but if the patient is BRCA mutant or BRCA wild, so irrespective of the status, all derived benefit. So in recurrent setting, whether you should use rucaparib and bevacizumab, that can be debated, as we have seen that Bev started along with chemotherapy in the patients. In those patients, you can add rucaparib along with the bevacizumab. So in recurrent setting, functional predictive biomarker is response to platinum, and HRD has not been able to provide additional predictor discrimination to identify patients who have not received PARP inhibitors. HRD negative patients respond to PARP inhibitors equally. So this is in the CRPC, we see that 11.8% of patients have these germline DNA repair defect, and 76% of the patients have this BRCA2 ATM check or BRCA type of mutation of these germline mutations of the 11.8%. And so this was approved by FDA in May 2020 for BRCA mutated metastatic CRPC by Triton 2 phase 2 response data. And in this, they had analyzed these patients who had these BRCA mutations in HRR genes and progression in 1 to 2 androgen receptor directed treatments and 1 taxane based chemotherapy. They were randomized to, they were given this rucaparib as a phase 2 trial. And these were the results. We see the deep response in most of these patients, and the PSA was also responding quite well. Median progression-free survival was 9 months, and median recurrence-free survival was 8.5 months. So OS data is yet not mature, but with a single drug, we see that it is having an impressive progression-free survival of 9 months. And these were the overall response rate. We see around patients who had confirmed PSA response rate were 63%. Only patients 9.2% progressive disease. Otherwise, most of the patients had either a partial response, 44.6%, or a complete response in 6.2%. So this was the Triton study which we are talking about, in which they had randomized this patient to either rucaparib or physician's choice. in which they had used either docetaxel or one of the oral agents, abiraterone or enzalutamide. So 55% of the patients had received docetaxel, 24% of these patients received enzalutamide, and 24% received abiraterone. And PFS, if we see that rucaparib was doing far better post 2 lines of these therapy, 11.2 months versus 6.4 months. So to conclude, rucaparib significantly increased PFS for the BRCA subgroup in intent to treat population, 11.2 versus 6.4 months. And this was the first clinical study to compare a PARP inhibitor with standard of care. And first clinical study of metastatic CRPC to demonstrate superiority to a docetaxel containing therapy. And another was the monotherapy rucaparib in pancreatic cancers. So we know that we do not have many options in patients who have pancreatic cancer. So in this, they had 19 patients who had measurable disease, who were treated with 1 or 2 previous chemotherapies, and rucaparib was given as 600 mg twice a day dose until progression. And this constitutes around 9% of pancreatic cancers. So we see that response rate in the target lesions with rucaparib was impressive. We know this post 2 lines would not have many options. So if this was the phase 2 study of maintenance rucaparib in patients with platinum-sensitive advanced pancreatic cancer, 16 weeks of platinum, or if platinum is contraindicated, they had 42 evaluable patients in which they saw the PFS of 13.1 months. So this works well even in the patients with pancreatic cancer who have a known deleterious mutations. With that, I'll conclude, and thanks a lot for patient hearing. Thanks a lot, Dr. Praveen.
So thank you, Pankaj. So for the wonderful lecture and finishing on time. So I have one question. So now we have rucaparib and olaparib, both the agents are there in the first line maintenance setting. And we know as per the inclusion criteria of SOLO-1 trial and the maintenance olaparib plus bevacizumab trial. So like olaparib and bevacizumab, so those were used in HRD positive patients, and the SOLO-1 used olaparib in the germline mutation patients. So if a person comes with HRD positive, and so will you go ahead with olaparib plus bevacizumab or rucaparib or olaparib alone? So because many a times cost is definitely a constraint for us, and we are not very keen in continuing with both the olaparib or rucaparib plus bevacizumab option. So what?
So if the patient's performance status is good, I think it's a matter of inclusion criteria. Otherwise, both the drugs are active in these subsets. So either we go for combination, or I think in this case, rucaparib can be a good agent, and we have seen in second line actually it's working irrespective of these mutations. So I think rucaparib happens to be a good option.
Okay. Thank you. If there are any other questions, I think we can discuss.
Sir, any experience with rucaparib plus bevacizumab?
No, I haven't started anything on the combination. So one of my patients is on olaparib plus bev, who is doing quite well. So single agent rucaparib I have used, but not the combination.
Okay. So with this, thank you, Pankaj. Thank you for this. And then I'll invite the next speaker, Dr. Sarthak Tandon, so who is a consultant in Rajiv Gandhi Cancer Institute. He is a radiation oncologist, and he'll be taking us through the topic of SBRT in early stage lung cancer. So Dr. Sarthak, over to you.
Just at the beginning, thank you, Dr. Praveen, for giving me this opportunity. Let me just share my screen. And so, are my screens visible? I mean, my slides visible to you all?
Yes, sir.
Okay. Right. So I've been given the topic of, I think we've been discussing this from day and ages, and it's been almost a decade that we've discussed what is the role of SBRT in early lung cancer. So without further ado, I'll just move on to the slides. So epidemiologically speaking, we cannot let go of lung cancer as a whole as a global index. We know that it's most common incidence in both sexes, and the mortality is very high. what is interesting to note is that we initially used to think that it's a Western disease, and it's primarily found there because of the practices and the lifestyle. But the recent data, which was showing that, in fact, the Western population, the incidence of lung cancer was going down, whereas in comparison to the Western data, the Indian incidence is increasing in. So this actually boils down to the fact that we need to also think about lung cancer as our disease and treat it locally. And similarly, the ICMR press release, which showed that there is a lot of confounding factors in Indian subsetting, and like the biomass and the indoor pollution, which has led to the increase of lung cancer in India. That's besides the point. But moving on to the exact topic, and that's SBRT. So we all know that if the patient is medically inoperable, the surgeon feels that the risk of surgery is pretty high, and going into surgery for lobectomy, either lobectomy, sublobar lobectomy, or pneumonectomy is at risk, then SABR is one of the options for these patients. And we have a lot of data for this. And it all started with Blomgren, who did the first phase 1 study, and we can see that the 3-year local control was pretty high for patients who were medically inoperable. But that is not the matter of contention. But the question was, we know that medically inoperable patients require radiations. Now, the data which supports SABR in comparison to a conventionally fractionated artery. Now, somebody comes up to me and say, no, I don't want a SABR. I want to go ahead and do a 6-week long course radiotherapy. Now, prior to 2015, we did not have a conclusive data to suggest that SABR is superior to our conventionally fractionated radiotherapy. But now we have phase 3 data to suggest that SABR is superior. So I'll move on to the main trial, which had shown that SABR is actually the technique to go ahead in early lung cancer. So it's a phase 2 data where PET staging was optional and biopsy confirmed stage 1 early cancer, medically inoperable. The dose was substandard, and probably that's the reason that there was similar PFS and OS in comparison to the conventionally fractionated radiotherapy. This trial was probably critiqued a lot for radiation technique per se. And that's the reason that this trial, the phase 3 data which came after that, which was the CHISEL trial, was frankly showed a superior result in terms of primary and as well as secondary endpoint, both freedom from local treatment failure and overall survival. And the reason being that they used compulsory PET staging, which is, in the current context, it is, we all use PET staging for lung cancers. And they used proper radiation technique. They had motion management, they had cone-based LINAC, the dose was adequate, and that's the reason that the results translated into a superior overall survival. And it's because of these trials that SABR was pushed as category 1 in medically inoperable patients. So again, I've been very quick in medically inoperable because the data is quite robust, and there is no doubt about that. And we have a lot of strict guidelines regarding how to treat them, what doses to treat them, where to treat them, and what fractionations to treat them with. The debate remains open for medically inoperable, and I was actually going across and finding data regarding this, and I found this article, which was actually very interesting. And they've come up with this data which showed that the result of a particular study was heavily biased on the first author. So if the first author was surgeon, the data portends towards the better survival in terms of, or better results for surgery vis-a-vis radiation, and vice versa as well. So this is something that we need to think about, that when we go ahead and search literature, we also need to search on various biasing factors, and the researching or the primary investigator and his specialty is one of them. So when you compare medically operable patients, and you know that there is no head-to-head comparison, and most of the trials which were started could not be completed because of slow approval. So we have to go with what's best available in literature. And that we all know from long back, that STARS Roselle combined data, which showed that the 3-year OS and 3-year OS was comparable with surgery. So I'm not going into the detail, but if you want to select, let's say if you want to really select patients who are amenable for SABR in a medically operable patients, where would you want to send your patients to a radiation oncologist? And you know that they being medically operable, but yet would want to opt for SABR. So this could be the need for preoperative histology and patients. There is a lot of data which suggests that if going in and taking a histology is at risk for patient, then doing a SABR in a without a histology is beneficial, and the risk is sometimes as low as 16% in comparison to the biopsy. Also, if there is functional inoperability, the patient is operable, technically speaking, but however, the functional operability is low. In those cases, also, you might want to opt for SABR in comparison to surgery. And obviously, patient refusal is one of the most important factors. And this also brings us to the fact that you need to give SABR as an option to patients who have early lung cancer. I've already talked about SABR without pathology, and obviously this is not something that you want to gun for. This is not a blanket statement. This is obviously an exclusion where you want to treat SABR without pathology, where the risk of pathology or going a biopsy is high. The patient preference of this was a data which came out in 2018, which showed that 56% of patients had no prior knowledge of SBRT before meeting a radiation oncologist, and those who underwent surgery, 80% were more satisfied with SABR than the surgery, and 90% would prefer SABR than surgery if given an option, again, probably in a recurrence setting. So Astro has recently updated their guidelines, and they have said that discussions about SBRT are mandatory, and disclosures about long-term outcomes, both with SBRT more than 3 years, are not well established, and that's something that we need to disclose to our patients. So this was also a data which came out, and this is the data of Netherlands. I think they are under publishing, and they've this slide is courtesy Dr. Suresh Senan, who's heading the SABR program in Netherlands. They found, and this is the real world data of clinical stage 1 NSCLC, and they found that in Norway, Netherlands, and England, where we know that there is no commercial practice, and the practice of surgery is going down vis-a-vis SABR, and SABR in early lung medically operable is increasing. This was the data which was, this came out in 2023. So this was the revised STARS cohort. So the same STARS data that we were talking about earlier, they've added more patients to it. And they've done a single arm study in comparison to a propensity score of the same MD Anderson registry. So it's a controlled phase, it's a controlled data. So not obviously as robust as a phased randomized trial, but definitely better than the retrospective data. And in the current setting, I think it's one of the most important evidences that we have. So the results showed that when you compare this with VATS along with mediastinal lymph node dissection, and that to systematic lymph node dissection, the 3-year OS was non-inferior. The PFS was non-inferior. The distant metastatic survival and cancer-specific survival were also non-inferior. The important thing that you need to notice, which came forward with this evidence, was that there is a higher rate of regional recurrence with SABR group. And this could be because PET was not one of the, there was incomplete mediastinal staging because PET was not mandatory in US, as we know, because of their insurance purposes. And that's the reason that regional recurrences were high. And but they were well managed, and they were salvaged. And that's the reason the OS was similar. So to conclude the evidences of SABR in medically operable, there is no RCT comparing surgery versus SABR. We have still data which is ongoing RCTs, and thankfully the accrual is going. They're going adequate with the current pace. The SABR-tooth and stablemates. Stablemates have come out with their efficacy data, and the efficacy is equivalent. So the meta-analysis of propensity score studies in early lung, they've also said that the lung cancer-specific mortality is similar, regardless of the extent of surgery. But the all-cause mortality was higher for SABR, again, because of a higher number of patients who were medically inoperable or probably were morbid enough not to go ahead for surgery. So despite reluctance, both survival and toxicity data arising from SABR and operable lung cancers are, we have comparison results in both toxicity and survival. And just to show, this is one of our data, one of our patients who've been treated for a lung. So the first CT for the early lung cancer that you can say, it's adjoining chest wall. I've taken this case because it's a difficult case. It's a chest wall adjoining and nearing to the mediastinum, where we know the SABR is difficult, but with the current techniques that we had, it's not that difficult. So the second CT is showing the C block is showing the 3 months CT. So the technical, as per the technical definition, it seems that it's a residual disease. But once we follow up, that's also one of the key factors for all of us to know that SABR results might be as delayed as 6 months to 1 year. So the 6 months PET showed complete response, and there was biopsy taken up, and there was no this disease. Similarly to this case, where the SABR subsequently treated, and a 6 months PET showed a complete response to the disease. So there is a specific radiological guideline where we need to assess. We cannot use the standard protocol and standard guidelines for assessment of response. There are specific guidelines and specific criteria to assess response to SABR, and that your radiologist or nuclear medicine specialist should be aware of. Thank you.
So thank you, Sarthak. It was a wonderful lecture, and this topic is always the talk of the town. So in early stage 1, whether to go ahead with SABR or whether to go ahead with surgery, because there are few patients who are literally scared of the surgery. However, the VAT surgery now has become a very kind of not a very toxic one. So I just want to ask one thing. So in your talk, so you touched upon a kind of scenario where you do not have histopathological proof, and there also people are doing SABR for these lesions. So are we talking about those lung nodules which are imaging wise, which seems to be a lung cancer, and their histopathological proof, if patient sometimes, so this is also a scenario where the patient is not willing for biopsy. So we often come across such a kind of scenario. So can we directly go ahead for SABR in those patients?
So what happened is that the data that I've taken up, it's primarily the data where lung screening was pretty robust. So they followed up those radiological images where they were very high in suspicion. So the serial imaging showed that there is some kind of, the specularity, the increase in size and increase in height. So the radiological suspicion needs to be high. I'm not saying that all patients should go ahead SABR without biopsy, but those patients, like you said, sir, those who are not willing for biopsy or where going ahead and doing a biopsy is at risk, and the incidence of treating benign lesions by SABR, the risk is less in comparison to the risk compared to doing a biopsy. That's how you do it. So it's not something which it should be your standard practice, but it's something that we should keep in mind, that we can go ahead and treat radiologically suspicious nodule where biopsy is not feasible.
Okay. So in those patients with medically operable disease, so how do we really go about the mediastinal staging? So it goes just like the normal situation, so where we do EBUS FNA of the EBUS mediastinal staging, and followed by, if there are no mediastinal lymph node, then you can go ahead with and do the SABR. So is it the same practice?
It's the same. So we use both. PET staging and EBS TBNA. That's the two modalities that you need to use, but the criteria is a little different. So let's say, for example, if your PET is positive and your EBUS TBNA is negative. So in those cases, your suspicion should be very high towards your node. You should be really very careful that your nodes are negative, and that's that's the place where your regional recurrences do occur. There's a data which suggests that when you retrospectively go ahead and see there in what patients do your regional recurrences occur, it's those patients where PET was positive but EBUS TBNA was negative. However, if the PET is negative and the EBUS TBNA is also negative, That's the best case scenario. So, but for the time being, what we are doing is, if PET is positive and the EBUS TDNA using proper Rose technique is negative, we go ahead and consider it as a mediastinal negative.
Okay.
Also explaining to the patient that there is 10% chances that we might have missed the disease in mediastinum with these two stages.
And you do not do the mediastinal radiotherapy in these, you just go and do the SABR for these patients. Okay. Okay. So if there are any more questions, I think we can ask Sarthak. So he's here with us. So I think, so we will thank you Sarthak for this wonderful lecture.
Thank you.
And we will go to the next topic. So the next topic is real world evidence of third generation TKI in EGFR mutated non-small cell lung cancer, and this will be taken up by Dr. Manish Sharma. So he's the senior consultant and head of unit in Action Cancer Institute. Dr. Manish Sharma, over to you. Thank you.
Is my screen visible?
Yes, sir.
Yes, it is visible.
Good evening all, and thank you so much, Dr. Praveen, for giving me this opportunity to share the real world evidence of osimertinib as a standard of care in the management of EGFR mutant NSCLC. So the patients with EGFR mutation, PFS improves after treatment with EGFR TKI compared with cytotoxic therapy. So osimertinib is an irreversible third generation EGFR TKI that has demonstrated a clinically meaningful overall survival benefit and PFS benefit as well. So overall survival benefit was 38.6 months versus 31.8 months. So there are multiple trials which have compared chemotherapy with the oral TKI, and one of these trials is osimertinib versus comparator EGFR TKI as the first line treatment for EGFR advanced NSCLC, that is FLORA trial. So this was the trial by the virtue of which the osimertinib got this approval for the EGFR mutant NSCLC. So FLORA is a double-blind study, and the inclusion criteria were EGFR mutant NSCLC, either exon 19 deletion or L858R mutation, with no prior treatment, any systemic treatment, and stable CNS metastasis. They were allowed in this study. The stratification was by the mutational status and the race, that is Asian versus non-Asian. The patients, they were randomized into osimertinib group versus the comparator EGFR TKI, and these patients, they were followed till either serious side effects or till progression as per RECIST 1.1 criteria. And the overall survival was key secondary endpoint, while the progression-free survival was the primary endpoint of this study. And these are the baseline clinical characteristics of the FLORA trial. And most of the patients, they were females, and the Asian were more than as compared to the non-Asians. Similarly, non-smokers were 65% compared to 35% smokers. CNS metastasis was allowed in this study, and 19 patients in the osimertinib arm had CNS metastasis. Histology was adenocarcinoma. And this is the primary analysis of the progression-free survival, and you can see that there is no subgroup which did not benefit from the osimertinib. And the progression-free survival here was 18.9 months versus 10.2 with the standard of care TKI, which was either erlotinib or Geftin. And this is the final analysis of the overall survival. you can see that the curve starts to separate from the very early institution of the osimertinib, and at first year, at second year, and even at third year, the curves are wide apart. And you can see that the osimertinib, the median overall survival was 38.6 months as compared to 31.8 months with the other first generation EGFR TKI. And at 3 years, 54% patients were surviving compared to 44% patient in the comparator EGFR TKI. So the conclusions of the FLORA trial was that this trial showed statistically significant improvement in overall survival and progression-free survival. And the monotherapy shows statistically significant overall survival versus another TKI. And after 3 years, 28% patients in the osimertinib arm and 9% of the patients in the comparator TKI arm remained on the treatment. So the drug has been approved for EGFR mutant NSCLC, and it has been given the preferred option as compared to the other EGFR TKI such as afatinib, gefitinib, or dacomitinib. So as of now, this osimertinib stands the preferred category option as compared to the other oral TKI. But the data on the clinical trial does not reflect the data on the real world studies. And most of the patients, they are examined and treated in the very strict clinical trial conditions. And hence we need some real world evidence about the drug so as to find how the physicians they are doing with that drug. So in this scenario, we are discussing 3 studies, that is FLOWER study, OCFAT study, and Mykonos study. This is the first study, that is FLOWER study. This is a brief introduction, and it says that the FLORA trial was initially shown the overall survival benefit and progression-free survival benefit. And based upon this, the FLOWER study was conducted. And you can see here, these were the key baseline clinical characteristics of these patients. The median age was 68, so older patients, they were included. Brain metastases were present in 30% of the patients. So that is total of 38 patients. And similarly, stage 4A and 4B were present in 30 and 90% of the patients. The inclusion criteria were similar to the FLORA study, and the exclusion criteria was the patient who had received the drug in the clinical trial. The primary endpoint of the study were median time to treatment discontinuation, rate of adverse events, and rate of dose reduction with temporary or definite treatment interruption. While the secondary endpoint were median overall survival, median progression-free survival, overall response rates, and disease control. So coming on to the effectiveness, the patients with poor PS, comorbidities, rare EGFR mutation, and active brain metastasis, they were included. And the outcome was similar to the published data, thus adding the consistency to the osimertinib efficacy, and no difference in PFS, time to treatment discontinuation, and overall survival were noted in elderly patients, patients with comorbidity or less common EGFR mutation. And you can see here the Kaplan-Meier curve for the effectiveness. The median time to treatment discontinuation was 25.1 months. Similarly, if we can see that the median time to treatment discontinuation, it was more in the patients who did not have symptoms at baseline as compared to those who had symptoms at baseline. And similarly, median time to treatment discontinuation was more in those patients who had less than 3 metastatic sites. So 3 or more metastatic sites if they were poorer prognostic patients. and trying to treatment. Sorry. This is the same table which suggests that the presence of the symptoms were the bad prognostic factors, and you can see that the hazard ratio, they were in the favor of the absent symptoms in these patients. So poorer treatment outcome with brain metastasis, presence of symptoms, and at least 3 metastatic site at diagnosis. So this is, and after median follow-up of 12.3 months, the median PFS was 18.9 months, and median overall survival was not reached at the time of data cutoff. The complete remissions were 0%, partial responses were 73%, and stable disease were 23%. Coming on to the median progression-free survival, the similar trend was seen with the median progression-free survival. Those patients who presented with the symptoms, or those patients who had more than 3 metastatic sites, they were having poorer prognosis as compared to those who did not have symptom at presentation or who have lesser than 3 metastatic sites. Median overall survival was not reached. So the longer progression-free survival was noticed in the absence of brain metastasis. Prolonged PFS and longer OS was also noticed in patients without symptoms at the diagnosis, and time to treatment discontinuation of 9 months was significantly associated with better overall survival. So 13 samples, they were available after the progression, that is 61.9% patient percent of the samples, and they were then gone for the molecular analysis to look for the resistance mechanisms. So the MET amplification was seen in 4 patients. MET amplification and EGFR amplification was seen in 1 patient. EGFR amplification alone in 1 patient, and HER2/neu amplification in 1 patient. Coming on to the safety data. The most common the side effects, they were diarrhea, stomatitis, dry skin, and paronychia and venous thromboembolism. So one thing is important to look at here. The venous thromboembolism was of any grade was seen in 9.5% patient, and the venous thromboembolism of grade 3 or 4, it was seen in 7.9% patient, which was statistically significant. But the venous thromboembolism was the most common, and in real world asterisk study, the grade 3 pulmonary embolism accounted for 2% of the pre-treated patients with the osimertinib. No difference in the rate of VTE was reported according to the age, PS, comorbidity, or tumor load. No difference in the survival outcome was observed according to age, comorbidity, and type of EGFR mutation. And this is osimertinib confirmed the efficacy and the safety in the real world scenario as well. This is another study, OSIFACT study, that is osimertinib as first line treatment for advanced EGFR mutant NSCLC in the real world setting. And the inclusion criteria were similar to the FLORA study, that is EGFR mutant NSCLC, and osimertinib as the initial treatment. The exclusion criteria were the patient concurrently using another anti-cancer therapy, patient undergoing post-operative adjuvant chemotherapy, or receiving osimertinib as second-line treatment. And these were baseline clinical characteristics. And important thing to note here is that the leptomeningeal disease were present in around 3% patients. In 1% patient, it was symptomatic, and in another 2.2% patient, it was asymptomatic. Pleural effusion, that is malignant ascites or malignant pleural effusion, was present in approximately 25% of the patient. Pericardial effusion was also present in 2% patient, and liver metastasis was present in 7.4% patients. The primary endpoint was progression-free survival, and the secondary endpoint was overall survival. time to treatment failure, response rate, safety, and post-treatment, objective response rate, and disease control rate. Efficacy analysis, primary endpoint, it was PFS, and PFS was 20.5 months. The other parameters that were significantly associated with progression-free survival was male gender, malignant diffusions, liver metastasis, and advanced unresectable cases. So these all have hazard ratios of more than 1. With respect to PD-L1 expression, median PFS was not recordable in patients who had TPS of less than 1%, 14.7 months in the patient with TPS of less than 49%, 11.1 months for those who had TPS of 50%. And this is the tabular representation of the same. You can see the males, they had hazard ratio 1.99. Malignant diffusion, the hazard ratio was 1.51. Liver metastasis 1.55. And the very late stage or heavy tumor burden 1.71, the primary endpoint. Discontinuation profile, the main reason for the treatment discontinuation was disease progression, which was in 44% patient. Another 25% patient discontinued the treatment because of the pneumonitis. 16% patient discontinued treatment because of the other adverse events. And 14.2% patient, the reason for treatment discontinuation was either patient request or patient did not follow up. So looking at this, the pneumonitis, the median duration of the onset was around 56 days. And it was seen in 12.8% patient. So this was a very significant finding from this study. Similarly, for the grade 3, less than grade 3 non-hematological toxicity, the median duration of onset was 53 days. And the conclusions were overall response rate was 76.2%, and the disease control rate was 94.1%. PFS is better with osimertinib than with conventional EGFR TKI. Median time to treatment failure was 19.1 months. And the median time from the start of treatment to the onset of adverse event was 56 days. Pneumonitis of all grades were seen in 12.8% patient and grade 3 or higher in 4.5% patient. And four patients had a fatal pneumonitis. So with real world study, you can see that the two most important clinical adverse events in these patients who were treated with osimertinib were pulmonary thromboembolism and pneumonitis, which we often just overlook these kind of side effects sometimes, which can be life-threatening as well. So the conclusion was the PFS after first-line osimertinib treatment in real-world practice was favorable, and the discontinuation rates due to adverse events, especially pneumonitis, requires further investigation. And this is another study. So this study reports the demographic and clinical characteristics and real-world time to new treatment or death and real-world time to treatment discontinuation of the patients with advanced EGFR mutant NSCLC who received first-line osimertinib. And the inclusion criteria were more than 18 years of age, advanced NSCLC, EGFR mutant, and initiated first-line osimertinib from April 1 to 2018. So this is the ongoing study, and the start date, the patient identification date was April 1, 2018, and by March 31, 2020, the patient identification ended. So those patients who were identified between these two dates, they were followed up and they're still being followed up. The interim analysis, we are presenting the results. It was done in June 30, 2020. So this was the socio-demographic characteristics. You can see here that median age was 70 years, which is much more than the those patients who were in FLORA trial, and 35% patients, so good number of patients, they were more than 75 years of age. So histology was most of the patients they had adenocarcinoma. Smoking history was present in 43% patients. So need to remember that sometimes we tend to overlook that the patient who is smoker and has adenocarcinoma may not have the mutation, but we can see here that 43% patients were smoker in this population. The Charlson comorbidity index was 2 or more in 13% patient, which clearly shows that the real world practices in which the poor PS patients, they are also included for the treatment. And evidence of brain metastasis was present in 33.6% patients, that is 184 patients. These were the common mutations. Exon 19 deletion were present in 51% patient. Exon 19 L858 beta were present in 33% patients. And at the interim analysis, 58% patients remained on first-line osimertinib therapy or were lost to follow-up. 18% received second-line treatment. And the second-line treatment was mainly PD-L1 or PD-1 monotherapy or combination therapy with EGFR TKI. 18% patient died while on first-line treatment, and 4.7% patient discontinued first-line treatment. And this is real-world time to next treatment or death. It was 17.9 months at the median follow-up of 9.6 months. The variables that were significantly associated with this were stage at initial diagnosis, smoking status, Charlson comorbidity index of more than 3, EGFR mutant type, and number of metastatic sites more than equal to 4. Real world time to treatment discontinuation was 17.2 months. And this was also significantly associated with Charlson comorbidity index more than equal to 3, ECOG performance status more than equal to 2, EGFR mutation type, number of metastatic site more than equal to 4, or evidence of liver metastasis. So the study provides the real-world insight into the use of first-line osimertinib in the patient with advanced EGFR mutant NSCLC based on first data cutoff. The real-world time to new treatment or death and real-world time to treatment discontinuation results support the effectiveness of the osimertinib in this real-world population. And the longer-term overall outcome will be evaluated in the final analysis. Thank you for your patient listening. Over to you, Dr. Praveen.
So thank you, Manish, for sharing the exhaustive list of real-world evidence with osimertinib. And it's always a pleasure that these real-world scenarios. So these are the exact scenarios in our clinical practice, and this re-establishes the role of this osimertinib as a preferred agent for EGFR mutated non-small cell lung cancer. Yes, we have seen thromboembolism and pneumonitis as the two most common side effects of special interest, so which were not seen very frequently in the FLORA trial. So I think the AstraZeneca people, they have to get back to the FLORA data and they have to analyze it again. So is there a miss in venous thromboembolism, or are there any particular monitoring criteria which are needed? So when we are starting the patient on osimertinib, so this is something which we have to look for. So if there are any questions, I think you can ask Dr. Manish about it. And I think if there are no more questions, so then we move on to the next topic, so which will be taken by me. So it is on the safety and toxicity of EGFR targeted therapies. So Dr. Manish, you'll have to stop sharing. So safety of EGFR TKI on the basis of safety and toxicity. So which one to choose from? So we now have first generation EGFR TKI, second generation EGFR TKI, and third generation EGFR TKI in our treatment armamentarium. And there are a lot of parameters which we consider while choosing one over another, and safety is one of the factor. So because most of the time, so these targeted therapies, so these are to be given for a very long time. And initially when the trial data came, so there were a lot of toxicity which were observed. And as Dr. Manish presented, with the real world scenarios and with more and more patients who are put on these drugs, so we are coming up with new safety concerns and new side effects profile which we have to see in the upcoming trials. So there are few basic slides like stage 4 non-small cell lung cancer could be M1A, M1B, M1C. So I'll not go into details of these. So the diagnostic workout, so biopsy is a must, and after that, so we have to test every adenocarcinoma patient for oncogene drivers, and our molecular pathologist said, so the next generation sequencing is the way to go. And at the time of progression on these targeted therapy, so biopsy should always be tried for, because there are a lot of targeted mechanisms which we can target with some next generation targeted therapies. So we know that with these targeted therapy we have come along like from 8 to 12 months of overall survival with chemotherapy to 38.6 months with the FLORA trial. So they have improved the outcome of these patients quite a lot. And we can see over here that there are a lot of driver mutation for which we have drugs available, and out of which EGFR sensitizing mutations happen in 17% if we see worldwide data. But if we see the Asian data, it is close to 30 to 35%. So we know that these druggable mutations, so these are basically enriched in exon 18 to exon 21, and with PCR we are particularly looking for these mutations, and in NGS also in hotspot mutations, so we are focusing on exon 18 to exon 21. So in India, the EGFR mutation positivity rate is 25 to 30%, and there are some Asian data where the EGFR mutation rate has gone up to 50%. And most common mutations, EGFR mutations, are exon 19 and L858R. These are categorized under the classification of common mutation, and rest of the mutation, they are classified as uncommon mutation. Almost 85% of EGFR mutation, they tend to fall in exon 19 deletion or L858R. And these, for these mutations, so the EGFR TKI are the first line of therapy. This is the time points where the trials have happened, and there are a lot of approvals which have come. And 2009 was the first IPASS trial in the first line, so which showed that gefitinib was better than chemotherapy, and it improved the quality of life also, and it improved the overall survival, progression-free survival also. And after that, over the last decade, so we had first generation, second generation, third generation, and plethora of trials had happened. So the initial trials, so they tried to test the TKI against the chemotherapy, and then with the availability of second generation TKI, so those were tested against the first generation TKI, and now with the FLORA, so it has been tried against the first generation TKI. So when we are selecting the first line treatment option in these patients, so we select the agent which should be safe and which should also be effective. So coming to the effectivity, so we can see over here the second generation TKI, which is afatinib, which was tried against gefitinib in the Lux Lung 7 trial. So there was not much progression-free survival advantage which was seen with this drug. So in dacomitinib, the progression-free survival advantage was there, but the maximum amount of benefit was seen with the osimertinib in the FLORA trial. And we can see over here so that there was immediate separation of the curve in the FLORA trial as compared to there was a separation of curve which happened at 6 months with the dacomitinib in the Archer trial. So the reason behind that was that there was some dacomitinib population which was inherently resistant to the dacomitinib. So this was the PFS analysis, and if we see the but across board, if we see erlotinib and gefitinib, which are the first generation TKI, so they give the PFS of 10 to 13 months. The second generation TKI, though, they give 11 to 14 months, and with osimertinib, it is more than 1.5 years. So with 1.5 years of drug or 14 months of drug, so safety definitely becomes a concern for us. And the gefitinib and erlotinib, so these are the reversible TKIs, so which inhibit the EGFR receptor reversibly. So afatinib, dacomitinib, and osimertinib, so these are irreversible TKI. And so this graph shows the activity of these EGFR TKI on the wild type EGFR and the mutated EGFR. So we can see over here the difference between the first generation, second generation, and third generation is, so with the progressive generations, so the activity on EGFR mutations, so they increases. And if we see the third generation TKI, which is osimertinib, it has got the least efficacy on least effect on the wild type EGFR receptor. So because of which the toxicity of third generation TKI is lesser as compared to the first or second generation TKI. And if we see the T790M mutation, which is considered to be a resistance mechanism to first generation or second generation TKI, so this is quite sensitive osimertinib to osimertinib, and thus giving osimertinib in first line, it has got dual advantage of creating less side effects, and with that, so it is efficacious against T790M also. So the frequency and severity of selected clinically relevant all causality adverse event, so that varies between the EGFR TKIs. And if we see, so the skin and the GI toxicity, these are the two main kind of toxicities which happen with these EGFR TKIs. And if we see the all grade rash, so it is maximum for with the second generation TKI and erlotinib as compared to osimertinib. If we see diarrhea, so we can see over here that afatinib, dacomitinib, so they predominantly have diarrhea and rash. And if we see the gefitinib, it has got more liver toxicity and ILD vulnerability. So there is a difference between the first generation TKI, and agent by agent also there is difference between the toxicity profile. So the second generation EGFR TKI, they have higher frequency of adverse event because of the pan inhibition of EGFR receptors such as rash and diarrhea. So usually the rash and diarrhea are mild to moderate, but at times so they can be severe also. And these rash and diarrhea, they appear more with the second generation TKI. So erlotinib and gefitinib in among first generation TKI, erlotinib has got more rash and diarrhea, probably because of the steady state plasma trough concentration, which is 3.5 times of gefitinib in erlotinib. And the liver dysfunction is more predominant with the gefitinib as compared to the erlotinib. So if we see any grade side effects with the second generation, first generation, and the third generation TKIs. So Archer 1050 was a trial comparing dacomitinib versus gefitinib, and we can see over here, so the diarrhea and the rash and stomatitis, so these used to be more common with dacomitinib as compared to gefitinib. And at the same time, if we compare osimertinib against the first generation TKI, so the diarrhea, GI toxicity. So those were comparable in osimertinib and the first generation TKI. So the conclusion here is that decomitinib, it has got more any grade side effects as compared to first or third generation TKIs. So if we see the tolerability profile of afatinib, decomitinib, osimertinib, so we can see over here that the grade 3-4 toxicity, so these were more common with the second generation TKI as compared to the third generation TKI, and 49% were the grade more than equal to grade 3 toxicity with afatinib, 63% with the decomitinib, and 18% with the osimertinib. So again, tabular form of grade 3, 4, 5 adverse events. We can see over here that in Archer trial, so it was more common with the decomitinib, and in Flora trial, osimertinib was equivalent to the first generation TKI. So another important parameter is the dose reduction, dose interruptions. So in Archer 1050, almost 2/3 of the population, study population in decomitinib arm, they required 1 dose reduction, and 1/3 of the population, they required the 2 dose reduction, and those patients, the dose was reduced to 15 milligram per day. So whereas in Flora trial, so there were only 2.9% of the patient who required dose reduction, and 13% of the patient, they required permanent discontinuation. So this is the analysis: 66% dose reduction in Archer, serious adverse event in 27%, comparing to 4% in Flora. So as first line treatment, second generation TKI, they lead to higher frequency of adverse events such as diarrhea and rash. So if adverse event severity does not lessen or cannot be managed, so there has to be some dose reduction, be it gefitinib, erlotinib, be it the second generation TKI or third generation TKI. So again, the dose reductions due to adverse event, we can see in Lux Lung 7, 52% patient required dose reduction versus 1.9% with the gefitinib. In Archer 1050, 66% versus 8%. In Flora trial, 4% versus 5%. So the first generation TKI and the third generation TKI, they has got least amount of dose reduction as compared to second generation TKI. So which have way higher dose reduction and dose interruptions. So coming to, so there was a post hoc analysis of Archer 1050, so which suggested that those patients who required dose reduction from 45 to 30 or 30 to 15, so when the efficacy analysis was done in these patients with who had dose reduction, so there was no decrement in the efficacy of the drug, and we can see over here that median PFS in all decomitinib treated patient was 14.7 months, and it was 16.6 months in those who had dose reduction with decomitinib. And in fact, the median overall survival and the overall response rate also, they were equally comparable with the all decomitinib treated patient. So dose reduction, they resulted in lower incidence and severity of grade 3 adverse event. However, even after dose reduction, the incidence is much higher compared to osimertinib in Flora. So we can see over here, so that after dose reduction also, so it is close to 4%, 6.7%, and with Flora osimertinib trial, so it is 2.5%, 1.4%. And in fact, more than that, so the post hoc data analysis, so these are neither the population nor the randomization model of statistical inference. And when we discover an apparent difference by an unplanned post hoc analysis, we may have discovered nothing more than simple coincidence. And this is something which we have to prove in the randomized trial. So whether the dose reduction, it doesn't lead to reduced efficacy. So this has to be proven with the prospective randomized trial. So coming to another aspect of safety and tolerability, those are the quality of life. And nowadays, most of the trials, so they are focusing on the quality of life parameter also. And we can see that LuxLung 7 compared Zafatinib to Gefitinib and showed that there were similar improvement in quality of life with both treatments. If we see in Archer 1050 study, so the quality of life parameter were better with Gefitinib as compared to Decomitinib. And in Flora, so the quality of life parameter were equivalent in Osimertinib and the TKI, first generation TKI. So all in all, the comparison shows that Decomitinib is a difficult drug to tolerate. So we can see over here, so here the positive side, so there is improvement in quality of life. And this side, negative side, so there is reduction in quality of life. So we can see over here that if we see the cough, dyspnea, pain in chest, pain in arm or shoulder, so all these there was a decrement in quality of life, and these were comparable in Decomitinib as compared to the Gefitinib. And we can see over here that diarrhea and sore mouth, they were more better with the Gefitinib as compared to Decomitinib. And if we see overall global quality of life, so it was better with Gefitinib as compared to Decomitinib. So but if we see in Flora trial, so both the arms, be it Osimertinib or EGFR TKI of physician choice, so they were having almost equivalent quality of life parameter. So these are other trials of first generation, second generation TKI who have studied the quality of life parameter with the questionnaires like FACT-L, TOI, and LCS. So IPAS trial showed that so this was EGFR TKI versus chemotherapy, and across trials, so they have shown that the quality of life parameter, they were better with TKI as compared to chemotherapy. If we see EGFR TKI versus EGFR TKI, so we have seen the conclusion in the first slide only. So LuxLung 7, so Gefitinib was equal to Afatinib. Archer 1050, Gefitinib was better than Decomitinib, and Flora, Gefitinib, Erlotinib was equal to Osimertinib. So coming to a very important aspect of management of adverse events, so particularly focusing on acneiform rash and diarrhea. So these acneiform rash and diarrhea, so these are a big problem with the EGFR TKI. And we can see over here that these side effects, so these are the least with the Osimertinib as compared to rest of the EGFR TKI. And these are graded according to the CTCAE grading. So grade 1 rash is when the BSA, so the rash is covering less than 10% of the body surface area. Grade 2 is 10 to 30% of body surface area. Grade 3 is either it is more than 30% or there are erosion and vesicle and desquamation. And grade 4 is that if there are blistering, erosion, ulceration, and epidermal denudation is present. So the grade 1, so and grade 2, the TKI has to be continued at the same dose, and the topical anti-inflammatory, topical steroids or clindamycin or oral antibiotic can be given for 6 weeks. If there are grade 3 or grade 4 side effects, so there we need to interrupt the treatment, and at the same time we have to consider 3 kind of therapies. So one are the topical therapies in form of corticosteroid, antibiotics. We have to give sometimes oral steroid also, and the third is the oral systemic antibiotics also is required in these patients. So with Osimertinib, similar kind of management is there. If there is more than equal to grade 3 rash, so we have to withhold the treatment. And if the reaction improves within 3 weeks, we have to resume at the same dose, or we can reduce the dose to 40 milligram per day. But if it doesn't resume within 3 weeks, so we have to permanently discontinue the treatment. So the diarrhea grade are tabulated over here. So this is over the baseline stool frequency. Like if a person is passing 2 stools per day, so the grade 1 is when the increase of less than 4 stools per day over baseline. Grade 2 is 4 to 6 stools per day over baseline. Grade 3 is more than equal to 7 stools per day over baseline. and grade 4 is the life-threatening consequences where urgent intervention is needed. So these patients with grade 3 or more diarrhea, so they usually require treatment interruptions along with the antidiarrheal management. And the antidiarrheal management consists of loperamide, diphenoxylate, atropine, or resicatrotide. So with these TKIs, gefitinib, we can do dose interruptions. Erlotinib, afatinib usually require antidiarrheal treatment, dose reduction, and dose interruptions. And osimertinib most of the times doesn't require any of these three. So the management of, so this we have already discussed. And to summarize, the second generation EGFR TKI, they are burdened by toxic profile. Adverse event leading to dose reduction in Archer versus Flora was much different. Almost 2/3 of the patient in Archer trial required dose reductions, vis-a-vis 2.9% with the Flora trial. So grade 3 or above adverse event, they were reported in almost 2/3 of the patient with the dacometinib. And also, apart from the toxicities, dacometinib deteriorated the quality of life parameter in these patients. So these are the guidelines which suggest osimertinib as the preferred agent, category 1 agent for EGFR mutated non-small cell lung cancer. So to summarize, we have osimertinib with the longest PFS, with the highest overall response rate and duration of response, with the least amount of toxicities, least amount of dose reductions, interruptions, or treatment discontinuation, and with the maintenance of quality of life parameter. With this, I would like to end the talk. And if there are any questions, I think we can take up the questions right now.
Dr. Praveen, so if someone has no finances for osimertinib, so which generation of oral TKI would you suggest for him? So you see that the dacometinib, when the dose were reduced, the PFS was very significant, and it was around 16 months, while osimertinib has PFS of around 18.9 months. So do you suggest using dacometinib with dose reduction for these patients, or you suggest first generation oral TKI when we see there is such a burden, it is burdened by such a toxicity?
Okay. So see, if it is because of the financial concerns, so osimertinib, the cost of osimertinib with assistance versus the cost of dacometinib, it is almost equivalent. Okay. So in those concerns, so dacometinib doesn't score over osimertinib. But if we just think in those terms that osimertinib is not available for the patient, and now we have the choice of first generation versus second generation TKI. So there are two kind of options which I'll be selecting. So first is dacometinib. I'll start with the reduced dose. So because we have post hoc analysis, I know, so there are problems with the post hoc analysis, but I would like to start at a dose of 30 milligram per day. And at the same time, another option is chemotherapy plus gefitinib. So that is also a good option, poor man's osimertinib. So where we have seen equivalent overall survival and equivalent progression-free survival with the gefitinib plus chemotherapy combination as compared to other options.
So pemetrexed plus gefitinib.
Yes. So I think if there are no more questions, so I think we'll close the session. So I would like to thank you all for joining and making this more interactive. I would also like to thank the academic partners who are AstraZeneca, Zydus, and Fresenius Kabi. And I would like to thank Horizon for conducting this event smoothly without any glitches. Thank you all.
Thank you, sir. Thank you so much. Thank you everyone for joining, and good night.
Thank you.
Good night. Thank you.